Good morning, everyone, or good afternoon, depending on where you're located. Welcome again to our E&M Game Day Winning Critical Care Denials webinar. My name is Ashley Decoto, and I am a specialist with our Provider Outreach and Education team. On the call with me today is my friend and colleague, Leanne Foster, who you just heard from, and Leanne is going to be helping out with the chat today. This webinar is part 2 of our 2-part series on E&M Critical Care Services. Yesterday, Leanne held the part 1 training camp, which provided more details on critical care services. If you were not able to attend her session yesterday, that recording will be available within the next week or so in the training center of our website and on our YouTube channel. We will also have a recording of this session available in the training center of our website, and Leanne will be adding a link for the training center to the chat. And it will be available there on our website for the next 60 to 90 days, barring any technical issues with the recording. And you can actually access this without having to access YouTube, as we do recognize that not everyone is able to access YouTube at work. The recording will also be available on our YouTube channel, as long as the information remains relevant and current. Also in our training center, you can find a copy of today's presentation. So if you haven't already grabbed that, it is still available for download if you would like to have the presentation to follow along or maybe to take notes, though it's not required. We are taking questions through the chat today, which again, Leanne will be monitoring, and I will check in with Leanne at the end of the presentation, time permitting, for any questions remaining in the chat. All right, for our agenda, we will start by doing a brief recap, again from Leanne's part 1 training camp webinar yesterday, where she gave a more comprehensive overview of critical care guidelines and the billing requirements. Again, if you were not able to attend that session, we do encourage you to review the recording from the Encore page on our website or again on our YouTube channel once that becomes available. After I provide that recap, I will be sharing the top denials and rejections for critical care services, and then the remainder of our session will be the interactive Q&A activity. All right, this slide, excuse me, this slide contains the acronyms that we will be using today. And I've gathered these all in one place so you have this for reference. And some of you may be familiar with these, but I did include these as we may have some attending who might be a little newer to billing Medicare and maybe not as familiar with these acronyms. Again, if you've not already downloaded the presentation, it is still available in the training center on our website, and you'll find that under live events. So please feel free to download that so that you have this slide as a reference. All right, let's start with a quick recap of Leanne's session from yesterday. First, critical care services are billed to Medicare only when the patient is critically ill or injured with an acute impairment of one or more vital organ systems. And we'll look a little bit closer at that definition when we get into our Q&A activity. We also have the critical care CPT codes listed here. So you have 99291 for the first 30 to 74 minutes. Then 99292 may be billed for each additional 30 minutes. Critical care codes are billed using time, not medical decision making. So documenting time is really key with documentation. If time is not documented, you're not able to bill for critical care. So next up, I want to share what our top denials and rejections have been at WPS for critical care services. And these denials and rejections that I'm getting ready to show you are based on claims data that I pulled for those critical care codes 99291 and 99292. First on our list is claims denied while the beneficiary is in a period of managed care. And this would happen when they're enrolled in a Medicare Advantage plan. So make sure that you're checking eligibility, which is something that you can do through our secure portal if you're signed up to use that. And if the beneficiary has a Medicare Advantage plan, that claim must be billed to that plan. Original or fee-for-service Medicare does not process those claims. Next on our list, we have duplicate charges, which might happen if payment was already made to you for a critical care service for that beneficiary on that date of service. Now, if you believe your claim denied duplicate in error, you may submit an appeal. And duplicate charges continue to be one of our top denials kind of across the board for E&M services. So you want to make sure that your billing system is not set to auto resubmit for your Medicare claims. Next is procedure must be billed with primary service. And this denial will happen if you bill 99292 without 99291. So 99291 is used for the first, again, the 30 to 74 minutes of critical care. And then 99292 is billed for each additional 30 minutes. So you can't bill 99292 without 99291. It must be billed on the same claim with 99291. We had a pre-submitted question which asked how to code to avoid denials. And this is really key for critical care services. If you bill to 99292, without 99291, you will receive this type of denial. The fourth one on our list here for critical care denials is expenses incurred prior to coverage. For this one, make sure that you're checking their entitlement date, which you can find either on their Medicare card or in our SecureNet Access portal if you're using that to check eligibility. And then last on our list is claim must be sent to the EGHP or Employee Group Health Plan first. So if the beneficiary has an employee group health plan primary to Medicare, you'll submit to that plan before billing Medicare. Here we have our top rejection reasons for critical care services. Our first rejection here is claim lacks information needed for adjudication. So something is missing from the claim. And you'll look at the other reason codes on your remittance advice, which will give you a little more information. This could be any of the items required for a claim to process, such as the patient's date of birth or your place of service, for example. So you'll want to double check your claim form and make sure that all the required elements are included and resubmit your claim. Next, we have rendering physician number invalid or missing. For these, it may say denied on the reason code, but this is actually a rejected claim. Also in your remittance advice, the reason code actually says to submit a new claim, which is exactly what you would do here. Double check that you've included the physician's NPI and that it's the correct NPI, and then resubmit your claim. The next one on our list here is claims for those beneficiaries who have railroad Medicare. And those claims must be submitted to the MAC or the Medicare Administrative Contractor who processes railroad claims. And that will be Palmetto to submit your railroad claims. You can verify that the patient has railroad Medicare by checking their Medicare card, and that would show Railroad Retirement Board in a red strip across the bottom of the card. Next here we have incomplete or invalid information for other insurance. If your claim is rejecting this way, you may want to check item 11 on your 1500 paper claim form, which is a required field, and you must include other insurance primary to Medicare in this field. If there's no insurance primary to Medicare, enter the word none. Leaving that blank on your paper claim form will cause your claim to reject this way. Now for your 837P electronic transactions, make sure that you're including the primary insurance policy number. But if there's not an insurance primary to Medicare, you would leave this blank for your electronic claims. For the last rejection we have here, we have missing, incomplete, or invalid provider primary identifier. And this rejection will occur if you're missing the NPI or have an incorrect NPI in items 32 or 33 on the 1500 claim form, or the electronic equivalent loops and segments on your 837P transaction. So this would happen, for example, if maybe you had a typo and keyed a wrong digit, or maybe you entered the NPI for the wrong practice location. So I've included this slide here as a reference to help summarize what I just talked about for our critical care denials and rejections. For rejections, you'll fix the error and resubmit the claim. Keep in mind that for rejections, the claim was not able to fully process, meaning that a claim determination was not yet made and the claim does not have appeal rights. Those must be corrected and resubmitted. For denials, your next step will really depend on the type of denial you receive. Your remittance advice will really be your best source to determine what's next. It may indicate that you need to resubmit your claim, in which case you can correct the error and resubmit. In some cases, you may be able to correct a minor error through a clerical error reopening using our SecureNet Access portal. So this might be to correct a keying error for your place of service or your procedure code, for example. And then you might have denials that will require you to appeal if you disagree with the claim determination. And your remittance advice would include the remark code MA01, which indicates that you have appeal rights. I did also include a link in the last bullet of this slide, which has information on how to appeal a claim. All right, next up we have our Q&A activity. And we've planned this activity to test your knowledge. So for each slide, we will be launching a poll. And we invite everyone to participate if you're able to. And then don't be afraid to take a guess if you don't know the answer. For each question, we'll give you a few moments to submit your answer, and then I'm going to talk about the correct answer. There are a few websites that you may want to reference for this activity, and I've asked Leanne to place links for those in the chat, so you'll have those handy in case you need them. I will be sharing each of these resources and pointing out a few key items to make note of as it relates to our activity. And you may also want to save these links to review a little more in depth later. All right, so let's get started with our polls. So our first question is, critical care requires medical care for a critically ill or injured patient with acute impairment of one or more vital organ systems. True or false? I'll give you just a minute to kind of figure out the polling feature here. All right, it looks like just about everyone got this right. The answer to this one is true. And this is in the Medicare Claims Processing Manual, Chapter 12, which is the first of your links in the chat for this activity. And I'm going to open that up and show you the information on critical care. So in this manual, we want to look at section 30.6.12, which begins on the bottom of page 57. So here in the first paragraph, right here, CMS indicates that Medicare follows CPT on the definition of critical care, which is the direct delivery by a physician or other qualified healthcare professional of medical care for a critically ill or injured patient in which there is acute impairment of one or more vital organ systems, such that there is probability of imminent or life-threatening deterioration of the patient's condition. So what does this definition mean? First, direct delivery of medical care means that the practitioner is actively working for that patient during the time provided for critical care. It's not necessarily limited to just face-to-face time, but it is time counted only for that individual patient. Next, the patient does have to be critically ill or injured, which according to this definition must involve an acute impairment of a vital organ system. So this might be maybe the respiratory system or cardiovascular system, for example, but those are just examples. The documentation would need to support that the patient has a very high probability of imminent or life-threatening deterioration. So the definition then goes on to tell us that critical care must involve high complexity medical decision-making to prevent further life-threatening deterioration of the patient's condition. So when looking at your documentation for these services, you'll want to make sure the criteria in this definition are met by not only the patient's condition, but by what you're doing for that patient at the time of service. Meaning the patient could be critically ill, but does the service your practitioner is providing involve the high complexity medical decision making? You'll want to look at CPT guidelines for the problems addressed, data reviewed, and the risk of complications, and make sure your documentation supports a high level of medical decision making. If it does not, you would not bill for critical care. We had a pre-submitted question asking to clarify high complexity, medical decision making. And again, you'll want to look at the CPT guidelines on choosing level of service based on medical decision making. And this is what will outline the criteria to meet that high complexity level. Leanne also did a webinar earlier this year on choosing your level of service, which includes information on medical decision making. And I've asked Leanne to place a link in the chat for that recording. We had another pre-submitted question, which asked for examples of documentation that meets the patient's severity that critical care requires. And you'll want to make sure that the documentation demonstrates the critical illness or injury, that it meets the requirement of one or more vital organ systems acutely impaired. But what's most often missed with the documentation is showing that high complexity medical decision making. And Leanne mentioned this yesterday too. It's not just about the diagnosis, but also there must be documentation that the service provided involves that high complexity medical decision making. One more pre-submitted question: is there a list of conditions that WPS considers inherently critical? And the answer to that is no. Again, it's really going to depend on your documentation to show that this criteria we just looked at here has been met. So I'm going to head back to the presentation, but I encourage you to keep this manual open for some of our other questions. All right, our next question is, what happens if the provider did not document time for critical care provided in the hospital? So select all that apply for which of these options best answers the question. Do you submit 99291, submit 99291 and 99292? You cannot submit critical care? And do you use medical decision making to submit a hospital service? All right, looks like most of the answers are in. The answer here is the last two. You cannot submit critical care if time is not documented, since these are time-based codes. In situations where the practitioner did not document time, you are able to use medical decision-making to determine your level of service and bill for a hospital service in this example. We had another pre-submitted question I want to answer here, which was, what documentation is required for billing critical care services that are new to critical care and used to billing by medical decision making? So for critical care services, the documentation must show that the patient has a critical illness or injury with acute impairment to a vital organ system. It will need to show what services were provided to that critically ill or injured patient. And it must be clear to a reviewer that the critical care services included the high complexity medical decision making. There must also be documentation of time. Again, if time's not documented, critical care cannot be billed to Medicare. All right, our next question is, which of the following are qualifying activities that may be included in critical care time? Select all that apply. Is it time spent at immediate bedside? Reviewing test results at the nursing station on the floor? Discussing critically ill patients' care with other medical staff? Or activities that occur outside the unit or off the floor? Looks like we've got a few more still getting their answers in. All right. So the first three on this one are correct. CMS refers us to CPT guidance on qualifying critical care activities. So what CPT says is that time reported as critical care is time engaged in work directly related to the individual patient's care, whether at the immediate bedside or elsewhere on the floor unit. They give the examples of time spent on the unit or at the nursing station on the floor, reviewing test results or imaging studies, discussing the patient's care with other medical staff, or documenting critical care services in the medical record. The CPT book also says that in situations where patients are unable to participate in discussion, time spent on the floor or unit with family members, obtaining medical history, reviewing the patient's condition or prognosis, or discussing treatment may be reported as critical care, so long as the conversations bear directly on the management of that patient. For the last answer listed here, CPT specifically calls out that these activities occurring outside the unit or off the floor may not be reported as critical care. All right, our next question is a scenario. Betty beneficiary was admitted to ABC Hospital last week, and Dr. Ross has been providing care. If Dr. Ross provided 25 minutes of critical care to Betty yesterday, which of the following may be billed using time? Is it 99291 or 99291 and 99292? Is it 99231? Or can the service not be billed to Medicare? Just another minute. We appreciate everyone participating, having a little fun on a Friday. All right. So the answer is 99231 for a subsequent hospital inpatient service. This service of 25 minutes does not meet the minimum threshold of 30 minutes. Therefore, critical care may not be billed. Dr. Ross is able to use a subsequent hospital care code in this case, which would be 99231 if using time. For our next question, we have another scenario. Today, Dr. Ross provides 85 minutes of critical care to Betty in the hospital. Which of the following may be billed using time? Is it 99291 or both 99291 and 99292? Is it 99285 or 99291 and G0316? All right. So the answer for this one is the first option, 99291, because he didn't meet 104 minutes to bill 99292. You can only bill 99292 in addition to 99291 if you have a full 30 minutes over the 30 to 74 minute time range, meaning you must have at least 104 minutes. We had a pre-submitted question on critical care time. Does the provider have to state critical care, in quotations, time, or will time statement be accepted if critical care is otherwise documented clinically? And the answer is that the documentation does not necessarily need to specifically state critical care time if it's clear that critical care services were provided. However, you want to keep in mind services that are billed separately, and that time must be clearly carved out in the documentation and not included in your critical care time. For example, if you're billing separately for, let's say, intubation, you would not want that time included in your total critical care time because you're billing separately for it. All right, our next question is, which of the following are considered bundled into critical care services and not separately payable? Select all that apply. Is it chest x-rays, pulse oximetry, ventilator management, or vascular access procedures? Give you just another moment. We still have a few getting their answers in. All right, so the answer for this one is all of these. CMS has a list of services that are bundled into critical care in the E&M services guide. And let's open that up and take a look. And this is the second, I believe, in your links in the chat. So, did not mean to close out of that. There we go. So the section on critical care in this guide begins on page 8. So the top paragraph up here outlines the definition of critical care, which we already looked at in the claims processing manual. And then it also tells us here that in this next paragraph that during time spent providing critical care, you can't provide services to any other patient. Just below that is the list of bundled services. So for anything on this list, such as chest x-rays or pulse oximetry, you would not bill for these services separately. They're bundled into the payment for critical care services and not separately payable. Keep in mind for anything that you are billing separately, again, that time should not be included in your total critical care time. We had a pre-submitted question which asked about services that are included in critical care time versus those that can be separately billed. Aside from the services in this list that are considered bundled into critical care, you may also want to check the National Correct Coding Initiative, or NCCI, procedure to procedure edits to make sure that your service is separately payable in addition to critical care. And Leanne will be placing a link in the chat in case you're not sure where to find that. All right, I'm going to head back to the presentation, but again, you're welcome to keep this open for some of our remaining questions. Next, we have Dr. Foster, who's providing critical care services for Betty beneficiary and Patty patient at the same time. Dr. Foster may bill for critical care services for both Betty and Patty. True or false? All right, looks like most of you got this one. The answer for this one is false. You can't provide services to any other patient. Your time would need to be focused on one patient who requires the critical care services. This would be a patient who's critically ill and needs the provider's undivided attention. All right, here we have another scenario. Dr. Geller provided critical care for Bobby beneficiary continuously from 11:15 p.m. Wednesday, November 19th until Thursday, November 20th at 1 a.m. Which of the following is the correct way to bill? Is it 1 unit of 99291 with date of service 1119 and 1 unit of 99291 with date of service 1120? Or is it 1 unit of both 99291 and 99292, both with date of service 1119? Or we have 1 unit of 99291, 2 units of 99292, both with the date of service 1119. Or then the last option, 1 unit of 99291, 2 units of 99292, both with a date of service of 1120. We'll give you a minute on that one. All right, the answer for this one is the second option, 99291 and 99292 with date of service 11/19/25. So let's break that down. We have a continuous service that goes through a midnight. There are a total of 105 minutes, which meets our threshold to bill one unit of 99292. For continuous services that cross midnight, you bill just one service using the date the encounter began as your date of service. So the care Dr. Geller provided to Bobby in this scenario began on the 19th and was continuous through 1 a.m. of the 20th. He would bill this using both 99291 and 99292, both on the same claim, with date of service November 19th, which is when that service began. Now, this is only because the service crossing midnight was continuous. If Dr. Geller had left at, let's say, 12:05 a.m. to go grab coffee with Dr. Foster and came back at 12:30 a.m. on the 20th, that would begin a new service on the 20th. All right, our next scenario is Dr. Green and Nurse Corey are in the same group and providing critical care for Peter. Today, Dr. Green provided 10 minutes of care and Nurse Corey provided 25 minutes. How is this billed? Would Dr. Green bill 99291? Would Nurse Corey bill 99291 and 99292? Would Dr. Green bill 99291 with modifier FS and Nurse Corey also bill 99291 with modifier FS? Or would just Nurse Corey bill 99291 with modifier FS? All right. So the answer is the last option here. In this scenario, we have a split shared service where both the physician, which is Dr. Green, and the non-physician practitioner, Nurse Corey, are providing a portion of the service. Since Nurse Corey provided the substantive portion, 25 of the 35 total minutes, he would bill 99291 with the FS modifier to indicate that this was a split shared service. Next, we have a true or false question. If a patient receives critical care services this morning and an E&M service this afternoon, both services are payable. Is this true or false? All right, so the answer for this one is false. Critical care and an E&M service can both be payable only if they are unrelated and could not have happened at the same time. So in situations where you have a critical care service in the morning and later have an E&M service, the E&M service is not payable. Now, if it were the other way around, where the E&M service was in the morning and the patient later needed critical care, the E&M service from the morning may be billed with modifier 25. And I'm going to open back up one of our resources, which is the E&M services guide. So we were out here earlier to look at the bundled services. So we're still here in the critical care section. But for this particular question, I'm going to scroll down to the bottom of page 9 and the top of page 10. Here, CMS recently added some if-then scenarios for critical care. And this would be a really good resource to save. These scenarios that CMS added, I think, are really helpful in determining how to bill critical care. Oh, I'm not done there. All right, so if I scroll down a little bit more, notice this last scenario right here. Same day E&M visit and critical care. This scenario is kind of the exact opposite of our question. Our question was about a situation where the patient receives critical care in the morning and then later that day has a non-critical care E&M visit, in which case the E&M visit was not payable. But for this if-then scenario, CMS tells us that if the patient receives a non-critical care service in the morning and then later that day develops the need for critical care, both services may be payable, but only if these criteria are met. So first, like with any E&M service, it must be medically necessary. The E&M service must occur before the critical care began. It must be distinct and not duplicative. And you must append modifier 25 to the non-critical care E&M code. I'm going to head back to the presentation, but again, feel free to keep this open if you're following along. For our next question, which of the following modifiers indicates the critical care service is unrelated to the surgery? Is it FT, 24, 57, or is no modifier required? I'll give you just another moment. I think this one might be a little bit tricky. All right, so the correct answer for this one is the FT modifier, which is used to indicate the critical care service is unrelated to the surgery during a post-op period. I'm going to open up the last of the resources in the chat for this activity, which is our WPS modifiers page. Let's see if I can keep this one open. Here we go. So here we have a list of the most common modifiers, which are all organized by category. Each modifier has a hyperlink to a fact sheet for more information and usually examples of correct and incorrect use for that modifier. So I'm scrolling down through these categories, which are in alphabetical order, and I'm looking for this section on evaluation and management modifiers. You can see in this section we have modifier 24, which was one of the answers that were not correct for this question. Modifier 24 is for non-critical care services that are unrelated to a surgery. That's why I said I thought this one might be a little tricky. So that's for non-critical care services. We also have our other incorrect answer, modifier 57, That one's used to indicate the visit resulted in a decision for surgery the day of or the day before a major surgery. And this is not one you'd use for critical care. I am going to click on this link for the modifier FT fact sheet and show you what we have out here. So this first section gives us the description of modifier FT, which is an unrelated E&M visit during a post-op period or on the same day as a procedure. And here we have correct use of modifier FT, where we see that this is specifically for critical care codes 99291 and 99292. Below that, if I scroll down a little bit, we have incorrect use, such as services other than critical care. Then we have some additional facts, including which modifiers to use if the surgeon transfers post-op care. We had a pre-submitted question which asked, is treating septic shock or acute renal failure considered billable for critical care in the global period with modifier FT? So if these complications are from the surgery, then no, they would not be billed as critical care with the FT modifier. FT would only be used if the critical care service is care that's unrelated to the surgery during the global period. If these conditions are not related to the surgery, then the documentation would need to support that it's unrelated and that the critical care requirements are met, and the FT modifier would be appended. The Claims Processing Manual, Chapter 12, which is where we looked at the definition for critical care earlier, that has some additional information on the FT modifier. It's in a section titled Critical Care Visits and Global Surgery. And that section is also listed down here at the bottom of this fact sheet. So that may be another resource that's helpful for you on your FT modifier situations. All right, let's head back to the presentation. Our next question is, providers in the same group with the same specialty may not bill 99291 more than once per day for the same patient. True or false? All right, looks like just about everyone has their answer in on that one. So the answer for this one is true. This is one of those if-then scenarios that CMS added in the E&M services guide. If multiple providers from the same group and same specialty provide critical care to the same patient on the same day, then they may add the time together to report 99291 just the once. And if they spend over 104 minutes total, then they may report 99292 for the additional 30 minutes. All right, our next question is, a cardiologist provides 30 minutes of critical care for Betty on the same day a pulmonologist provides 45 minutes of critical care. Which of these statements are true? Only the pulmonologist can bill 99292. The cardiologist and pulmonologist can each bill 99292. The cardiologist and pulmonologist can each bill 99291, or neither can bill. I'll give you just another minute. We still have a few answers coming in. All right, excuse me. The answer is that the cardiologist and pulmonologist can each bill 99291. If multiple providers from different specialties are caring for a critically ill patient on the same day, each is able to bill their service, so long as the services are distinct and not duplicative. And the documentation would need to support that. All right, our last question is another scenario. Dr. Smith performs a heart bypass surgery for Betty and transfers post-op care to Dr. Green. Now Betty has COVID-19. Today, Dr. Green is treating Betty's COVID-19 and providing post-op care. Which modifiers would Dr. Green use for critical care? Is it FT, 55, FT and 55, or 54 and 55? Got a few more still getting their answer in. Give it just another moment. All right, so the correct answer here is the third option. Dr. Green would use modifier FT and modifier 55. If a surgeon transfers care to a critical care provider and the critical care does not relate to the surgery, the critical care provider would append both FT and modifier 55 to the surgery procedure code. And that information is in that FT modifier fact sheet we looked at. All right, here are your resources for critical care services. First, we have the Evaluation and Management Services Guide, which we've looked at a couple times today. And this is the resource where CMS has those scenarios for critical care. And that might be a good one to save as a favorite, as it really covers all types of E&M services. The other resource listed here is the Medicare Claims Processing Manual, and that's where we looked at how CMS follows CPT guidelines for the definition of critical care services, and it's also got some good information on the FT modifier. All right, we do have a couple minutes and I'll check in with Leanne. Leanne, do we have any questions remaining in the chat?
Ashley, we do not have any questions remaining.
All right.
Oh,
So
Ashley, I am sorry. We just had one come in. The question is, for CRNA pass-through method 2 call, can both CRNA and MD bill the 99291?
Leanne, I'm not sure that I have the answer to that. I may have to take that one back.
And that, yeah, I do want to take that one back as well. One thing I do believe, though, because that CRNA and that MD are going to be considered that different specialty, they may be able to, but with method 2, there are some unique rules. So we're just going to take that back and just confirm that, and we'll get you an answer.
Yep. All right, great. So like Leanne said, we'll get that answer out to you. If you do think of any additional questions, you have 7 days to submit those to us, and you'll send those to our education mailbox. And make sure to include the title of this webinar, Winning Critical Care Denials, in the subject line, so that they make sure those emails come to Leanne and I. Please keep in mind that I'm not able to access any claims history, so you will want to contact customer service for any claims related questions. In a few minutes, you will receive an email to thank you for attending, and you don't want to delete this one without reading it. The email contains your certificate of achievement, and it will have your name and contact hours if you need to turn it in for credit towards continuing education units. If you do not receive this email, a few things may have happened. First, you may want to check your spam or junk folder. Also, make sure to add messenger@webex.com to your safe sender list so that any future messages for these events will show up in your inbox. Also, if you joined by phone only, you would not have received this email, as there's not a way for us to capture your email systematically from our attendance record. But no need to worry. If you joined by phone, you are able to email us with a phone number you joined with to request your certificate of attendance, and I can verify your attendance that way. And Leanne will be adding that email address to the chat. All right, please take a few minutes to complete our survey. Tell us what you liked, what we can do better. Also suggest topics for future education. You'll have a few different options to take the survey. You can use the link in the chat, or when you exit today, you'll be prompted to go to an external site, and that external site is the CMS Qualtrics page. The prompt will look like the picture we have shown here with the little yellow triangle. And we included this image up on the top right of this slide so that you know this is safe. It's not malware or anything like that. For those that might be listening through our website or through YouTube, you also have the same opportunity to provide feedback. You will have a survey card at the end of the presentation, and you can scroll to the end to see the link, and the link is also available in the description. All right, that concludes our webinar. On behalf of myself, Leanne, and all of Provider Outreach, we thank you for taking the time to join us. We really appreciate your participation today. We look forward to your survey feedback, and we hope to see you again at future events. Everyone stay warm, have a wonderful weekend, and you may now disconnect.